next talk is entitled Extracorporeal Life Support in Congenital Diaphragmatic Hernia. Is center volume associated with mortality by Dr. Alice Martino.
Thank you. The mortality rate for infants with CDH on ECMO has remained near 50% since the early 2000s. However, previous studies have shown that there's differential survival of these neonates based on the center at which they're treated. Specifically, higher volume centers have improved outcomes. However, this volume mortality relationship has not been described for CDH neonates in the ELSO database, which is the largest international ECMO registry. Previously, we've shown that there is a wide variety in the standardized mortality ratio for ELSO centers, with certain centers performing significantly better and some centers performing significantly worse than average. This pattern is also seen in the CDH study group data, where infants with CDH, both on ECMO and not on ECMO, are contained. However, these studies were not designed to evaluate process of care variables like center volume. Therefore, we sought to evaluate the association between center volume and mortality for neonates with CDH on ECMO. We hypothesized that higher center volume is associated with lower mortality for CDH neonates who are treated with ECMO. We started with the CDH ECMO cohort from 2000 to 2019, and then excluded all centers with less than 10 cases over the 20-year study period. We also excluded infants with bilateral or unknown laterality of CDH and those with unknown ventilator type, with a resulting 4,985 neonates at 120 centers. We then performed a hierarchical logistic regression with random effects to account for center clustering. Our primary outcome was mortality at discharge, and secondary outcomes were on ECMO complications. Our exposure was center volume, which we looked at both as a categorical and continuous variable. Previously, low-volume centers were defined by Janselowitz et al. As centers that with less than 10 CDH cases a year. For this study, we wanted to look at what's considered low volume for CDH ECMO cases. We assumed a 20 to 30% ECMO utilization rate, and taking the lower border of that, 20% of 10 annual cases is 2 CDH ECMO cases a year. So our volume groups were low volume with centers that performed less than 2 annual cases, medium volume, 2 to 5 cases a year, and high volume were more than 5 of these cases annually. In the 120 ELSO centers in our study, the mean center volume was 2.1 cases a year, with 1.6 cases a year as the median. When examined as a continuous variable, higher center volume was associated with a reduction in the odds of mortality. In other words, an increase of 1.75 cases is associated with a 16.7% lower odds of mortality. Volume was then examined as a categorical variable, and lower volume centers were associated with a 54% higher odds of mortality relative to high volume centers. This is a significant effect size and is comparable to an additional comorbidity or the prenatal diagnosis of CDH. Overall, our data show an inverse relationship between center volume and mortality, with our average center mortality being around 50.6%, which is consistent with prior data. However, we still see some data variability, suggesting that other factors besides center volume may be influencing mortality. When examining complications on ECMO, only infectious complications were associated with center volume, with both low and medium centers having higher rates of infection than high volume centers. In conclusion, there is a risk-adjusted relationship between center volume and outcomes, with higher center volume conferring a significant survival benefit and decreased risk of infection. Future studies are aimed at detailed center-level data to analyze practice patterns that may account for these disparate outcomes. We also see the development of a CDH quality improvement type of program for ELSO centers, with the goal of guiding best practices and improving care for CDH neonates on ECMO. Thank you.
questions?
Good morning, Terry Buckmiller from Boston Children's. Thank you for sharing your data with us. Were you able to look at whether or not these children were actually repaired on ECMO, and if some of the differences could have been an intention to treat versus a non-repair?
Yeah, thank you for that excellent question. Repair rate on ECMO was one of the variables that we included in our analysis, specifically for that reason. And I think that's also helpful to sort of help us figure out severity of those infants. So we're not excluding those that are not repaired.
Great, thank you.
Ron Herschel, Ann Arbor. Did I understand that the average ECMO center did 1 to 2 CDH cases per year? So that's amazingly low, and for these very complex patients. And I guess my question would be your thoughts, to get your thoughts on whether we should be centralizing CDH care on ECMO or CDH care in general.
I think that's a really important question. And this is not a common pathology, as we see most people, like you mentioned, are not performing many of these a year. We are interested in looking at if there's differences between the centers. Is it purely just based on how many they see a year, or are there differences in the protocols that may be replicable in other centers? That's not something that this study was designed to evaluate, but it's definitely something that we want to look into in the future.
Stoller, Santa Barbara. Thank you for continuing to use the ELSO registry. We started this back when the Earth's crust was cooling. It's a pleasure to see the database continue to be used and mined for interesting information, so thank you for doing that. A couple of comments. One is, why are there only, should we centralize, to respond to Ron Herschel's question? An ECMO patient in a NICU is one of the most high-value beds in a children's hospital. A kid on ECMO is worth about $125,000 to $150,000 a day to the hospital. Not to the doctors, but to the hospital. So there's that issue why there's the impetus to hold on to those patients. The other comment is, more often than not, these patients are now cared for by neonatologists, not us. When I talk to other pediatric surgeons at other neonatal units, more often than not, the day-to-day, minute-to-minute bedside care is not by us, it's by neonatologists, and I would suggest that we've abandoned that responsibility. I have a couple of comments about the data. One is, you may not be able to learn this from the database, but if you're able to look at centers where the child is born in the children's hospital versus transported from elsewhere. It was a number of years ago, Scott Adzik wrote this paper, I think it was Scott Adzik wrote the paper about the hidden mortality. It's real. And if a baby's transferred to your hospital for ECMO as opposed to being born in the hospital, those hospitals where the delivery is in the building, where the neonatal unit is and the surgeons are, the mortality is going to be lower because the hidden mortality goes away. So consider that. And the other consideration, and again, the data are not in the database, but what was the respiratory care strategy? Was it paralysis and hyperventilation? Was it spontaneous respiration and permissive hypercapnia? What was the respiratory care strategy? Because I promise you that has an impact on outcome. Thank you.
Thank you so much for your comments.
Thank you. Thank you.